I'm assuming everybody's familiar with epilepsy, otherwise why would you be here?
Yeah.
But it's a...
No, I'm not.
What's that?
I'm not.
You're not?
We're
new
to
to
it.
Yeah,
You're new?
we're new.
Okay.
So
Well, don't... Yeah.
you know,
It's funny because I have patients who come in all the time, and I'll take a second to go through this because we have these slides by now. And I'll ask them a couple basic questions because they are mostly referrals, and they'll come in. And the first question is, well, has anybody ever explained to you what's a seizure and what is epilepsy? And you would think, because the average patient comes, they've had seizures for 15, 20 years at this point. You would think that the immediate answer, oh yeah, I've heard like 5,000. No. 90% of the time, they're like, no, nobody ever actually explained to me what this was, which always kind of amazed me because I kind of want to know. So maybe we'll start with that. And we'll talk about some stuff. What it is, what is treatment-resistant epilepsy, because if the epilepsy responds to therapy, then it's pretty straightforward. We'll talk about that. And then what the different treatment options are. And yes, if you want, I'll even throw in a couple of words about CBD oil and medical marijuana and all the other stuff I get asked about all the time. Only 3 to 4 times a day. I usually point to the airport. Denver's. So, well, statistics, 5% of the population is going to have at least one seizure in their lifetime. That's 1 out of 20. So you got some definitions in here. I will give you exactly the same explanation I give every patient in my office, which is, and this goes from the bricklayers to the PhDs, doesn't make any difference. Because this is the way I think about it. I have a simple mind, so this is as I understand it. Your brain operates by a kind of electricity. If you could see it, that electrical activity would be completely chaotic. It would look kind of like my teenagers' rooms. You walk in there and nothing. You have no idea where anything is. And God forbid you clean it up because then they'd be helpless. They wouldn't know what to do. And that's because...
Okay.
Even if you do something simple, like reach out and pick up a pen. That's pretty straightforward. Right now, there's part of my brain that's seeing the pen, identifying the colors. Yeah, I'm colorblind, so half the colors you guys see, but still identifying the colors, that it's a pen, what you do with the pen, the word pen, what it sounds like, how it's spelled. Part of me is controlling my hand and the fact that it doesn't pick up a pen like that, it picks up a pen like this. And I'm continuing to talk and continuing to convey some information and make a point, which eventually I'll get to.
Okay.
Each part of my brain at that moment is doing something slightly different, totally chaotic. So something changes your brain in such a way that the electrical activity, that all the neurons, the brain cells in one area, are all firing off at the same time. That's not normal. That effectively is a short circuit. That's a seizure. Now, what it looks like, the clinical manifestation, what everybody else thinks of as a seizure, really depends on where it is and how far it spreads. So, if it's over a motor area on the left side, my right arm might shake. Move a little higher, my leg will shake. Move to the other side, back a little bit in a sensory area, I might feel a burning or tingling sensation. Put it back in the visual area and I'll see some sparkling lights or overt hallucinations. Put it in the right spot, I can have this powerful feeling of deja vu. I can get, my heart rate can accelerate, I can get feelings of fear. And actually, if you follow enough patients with epilepsy, eventually you realize that virtually every human experience has been reproduced just about by somebody having a seizure at some point. Rising and floating out of body experiences, you name it. Now, those are seizures. But is that epilepsy? Well, I usually use the example of medical students because there are lots of them and who cares? And they don't let us do this to medical students anymore anyway. So, well, all right, let's take something that everybody doesn't like. Hospital administrator, lawyers?
Lawyers.
Any lawyers in the audience? Okay. So, let's say we take a lawyer, and I'm pushing it because we got to extrapolate to human, but let's say we start with a lawyer, and we give the lawyer the right chemical, right poison, amphetamine, cocaine, there are a variety of toxins that can do this. He'll have a seizure, generalized convulsion. He'll keep seizing until we stop giving him that compound, and then he'll be mad, but he won't have any more seizures. That's not epilepsy. And there are lots of circumstances where people can have seizures that are triggered by antibiotics, over-the-counter medications, illicit drugs, a variety of reactions, and they're single seizures or a couple of seizures related to that acute state, and then when it goes away, they're fine. But let's say I take the same lawyer, because we don't like the guy apparently.
That's right.
And he gets a head injury, and he gets some type of scarring over his brain. Now, totally independently of anything else we do, he can spontaneously generate seizures in the future. Anything that causes the brain to change in such a way that it can generate seizures on its own, that's epilepsy. Now, do you have to be having seizures to have epilepsy? Well, we used to say that all the time, right? Because what does a doctor say to you when you go into the office? How many seizures have you had? You go, I've had 15. And he writes it down, or she writes it down. And he goes, and if you have 0, that's good, and if you have more than 0, that's bad. It's actually a little more complicated than that, because you can have seizures at night while you're sleeping. Nobody sees anything. We bring people into the epilepsy monitoring unit. They'll have seizures, and they won't notice anything. Their families don't notice anything. But if you test them over time, let's say the seizures are near a language area, a little more trouble with word finding. You can't remember words as well as they used to before the epilepsy started. And if you look at a group of people suffering from epilepsy as a whole, you see a higher incidence of things like depression, anxiety, attention deficit disorder, sleep disturbances. And all of these things are directly or indirectly related to the seizure activity, and they can be just as problematic or even more problematic than the seizures themselves. So the growing thinking is that epilepsy isn't simply a disease of seizures. It's easy to think of it that way, and if you're a physician, it's really convenient, because then I can say, okay, well, I made you better, you have none. But it's bigger than that. There's a lot of comorbid conditions, we think of it as a spectrum disease now. And you have to pay attention to everything that's going on in the patient's life, and not just focus on the seizures by themselves. So we have we like buzzwords. Ictal phase, so we'll talk about postictal and ictal. Ictal means the event, that's the seizure. That includes the aura, and you've heard of people having auras, or you have auras before your seizures. The aura itself is a little seizure, because if you start with a small seizure, you might have what we call a simple partial seizure. Consciousness is not impaired. That's the feeling of doom, or the rising sensation in my stomach, or the sparkling lights at the point that I go to my family and go, it's coming. That little event, that's still a seizure. Postictal phase, that's after the seizure. And when you ask a patient, or when you ask family members, how long was your seizure, kind of makes sense. There's a little blurring there, because if I'm looking at a family member, and this happened to my nephew about 3 years ago, and I'll do a little digression here. And it illustrates the difference between being a family member and being a physician. So this is a true story. 3 years ago, in Fisherman's Wharf, with my brother, who's a family practice doctor, does a lot of emergency medicine work. And me, I've been doing epilepsy now 26 years. Right? And my nephew, who's like 6 million feet tall, he's about 6'4", big guy, 23, 24 years old at that point, decides to have on, Fisherman's Wharf, has his first generalized convulsion at about this distance. So my brother and I are staring at him as his head turns to the left. I remember that part. Head turns to the left, he falls down, there's this gigantic seizure. My brother turns to me, panicked, he goes, "What do we do?" And I went, "Call 911?" When it's your family member, you know, it all goes out the window. True story. He ended up in the emergency room at Cal Pacific, and a friend of mine, one of the epileptologists on call, said, "Wait a minute, Slater's your uncle? He doesn't know what to do?" Yeah, I know. But it's even understanding it. It is, if it is someone, if it's you or it's somebody that you care about, it is absolutely terrifying. And it is one of the hardest things to convey to doctors in training, residents, fellows, etc. And one of the advantages to an epilepsy monitoring unit is that they actually get to see seizures in their entirety, and not just coming in at the end when the patient is recovering. They're somewhat confused, but they're not doing any of that stuff. And it's helpful from an educational standpoint, but it doesn't make any difference. My mentor has been doing this even longer than I have, and when his youngest daughter had a febrile seizure, this benign febrile seizure, they recover, they do fine. In the middle of his living room, what do you think he did?
Call 911.
No, he screamed for his wife. He couldn't even call 911. Right. If you ask somebody, and this is related to this, if you ask somebody, how long does a seizure last? Right? And I get 15 minutes, 20 minutes, an hour, 2 hours. I know from personal experience watching that seizure. I know it was about a minute, time-wise. Felt like 2 hours. Average seizure, though, is less than 2 minutes in duration. You actually look at the electrical activity. Lasts longer than that, you're potentially in a condition called status epilepticus, which is unfortunately more common than we'd like to think. If you look across a group of people who have epilepsy, having them present with one seizure after another when it's poorly controlled is not that uncommon. But that's a potentially life-threatening event.
Can I ask you a question?
Sure.
So, when your nephew had a seizure,
Yeah.
was he later diagnosed with epilepsy?
He was not.
So what brought on the seizure?
We don't know.
He never had another
How
one?
He
long
never
was it?
had another one. He had an imaging study that was entirely negative. He had an EEG that was normal. And under those circumstances, first-time seizure, most physicians will elect to wait and see and say, "Don't drive." But they'll wait. And to date, and this has now been 3 years, he has not had another event. And there can be all kinds of speculation about why someone has a single seizure. Sometimes you eventually identify, oh, it was the antibiotic that you were taking, or oh, it was this, or oh, it was that. A lot of times we don't figure it out. And my best guess, and take this with this gigantic grain of salt because I don't know, is that there are very subtle changes that can take place in the development of the brain. These are called malformations of cortical development. They're very common in the patients that we see, that we end up doing surgery on. If you get imaging studies, you get MRIs and everything, their brain looks perfect. They still have bad seizures, so me telling them that their brain is normal is not making them feel any better because they're still having all these seizures. When they finally go to surgery and we have the seizure focus or the zone now in a jar, pathologists look at it, the microstructure in that tiny little area is abnormal. And I think of this as, like I said, I have a simple mind. And if you recognize this, it tells you something about your age, or you watch a lot of Nickelodeon. I think of it as the Bugs Bunny effect. So if you watch old Bugs Bunny cartoons, right? Bugs is like tunneling along, tunneling, and he pops his head up, and he's in the middle of Saudi Arabia, but he looks around and goes, "This ain't Albuquerque." Jeez, how is this relevant? When your brain develops, I mean, one of the miracles is you start with one cell and it turns into 2 cells and 4 cells and doubles, and then eventually it's a teenager who can't find a job. But, okay, that was a little 2-cell reference. But one of the miracles beyond that is that the cells that become the brain differentiate into the neurons. And they don't just cluster together to form this mass, but they form this incredibly detailed structure. And the gray matter is on the outside, and the white matter is connecting everything together, and they essentially swim along, following some chemical signals, and set up shop out here. And some of them get lost. In almost everybody, in almost every major organ, as the organs develop, some of the cells are like, this looks like a good place. And they stop. They're normal neurons. There's nothing wrong with them. They just happen to be in the wrong place. And if you do autopsies on a bunch of people, you will find clusters of these things in a decent percentage that are just sitting there. And they've died from old age and happiness. What the neurons can do potentially is if there's enough of them, they do what neurons do. They start making electricity. And it may do nothing, and it may trigger seizures when they're 1, or 10, or 100 years old. And my guess, it's a long-winded guess, my guess would be that that's what happened to my nephew. That he's got some little tiny cluster that particular day, San Francisco, I don't know, sleep deprivation, having too much fun, being too close to his uncle, I don't know. That's what triggered the event. And he may never have another one for the rest of his life. Now that's fortunate. I mean, nobody wants to have a seizure, but if I was going to have a seizure, I would elect to have one and not have another one. It's when it's recurrent and you have epilepsy, this is where it becomes a problem. Now, we've got definitions. Generalized seizures affect the entire brain. Electrical activity spreads and involves the entire brain, and it can produce either what you think of as a generalized convulsion. When I say seizure, most people are picturing like a rerun of House and somebody shaking on a gurney. Or it can produce a generalized seizure, can just sort of produce an absence event, a staring spell, where people are just sort of shut off, like they put in neutral for a few seconds. But you can also, what we talked about in the beginning, were focal seizures, where the seizure starts in one area of the brain, may produce an aura, no impairment of consciousness. If it spreads a little bit further, then consciousness is at least impaired. Patient's probably not going to remember what's going on. They may do funny things, pick at the air, pick at their clothes, wander around. They may even engage with you, depending on where the seizure activity is located. You'll have entire conversations with their conversations are entertaining because they don't make any sense. But they won't remember them afterwards. And the seizure symptoms, like we said, are related to the part of the brain that's affected by it. So, more than 2 unprovoked seizures, that's epilepsy. Half to 1% of the world population, 3 million people in the United States, about the same incidence as type 1 diabetes. 4th most common neurologic disease. So what do we want to do when we treat people? Well, all right. There's one other thing that I'll mention, actually, so I'm going to wander all over these slides and we'll see how many of them we'll get through. We think of epilepsy and we think of seizures and we think of epilepsy, and then the epileptologists have one more concept that they deal with on a regular basis. These are epilepsy syndromes. But an epilepsy syndrome is a particular collection of symptoms and pathology, and if you put it all together, if you fit into one of those syndromes, then I know a lot then about prognosis and treatment and genetics and a whole bunch of other things. And I'll give you a couple of examples. I'll give you 2 examples I see probably most commonly. There is, in fact, a patient came in yesterday, and from her standpoint, I think she was about 26. From her standpoint, her seizures started about 5 years ago. She had a generalized convulsion. And we worked her up and said, eh. And then she had another one, and they said, you got epilepsy, and they placed her on some medicine. And she had a bad reaction, they put her on another medicine, she's been fine. So from her standpoint, she's had 2 seizures. We start talking, and I ask her, she gets a warning before the seizures, and she says, yeah, I get the shakes. And what she's actually describing are these brief, rapid contractions called myoclonus. And almost everybody in the world has experienced myoclonus. Because if you want to know what it's like, come to me giving a lecture to medical students, and somewhere in the audience, one of them's going to be dropping off, and right before they fall asleep, they jerk. So most of you've had the experience, you're just about to fall asleep and you jerk. Right? Electricity running through you, that's a kind of a seizure. It's a benign one. It's called hypnic myoclonus. It's utterly normal, doesn't mean you have epilepsy or anything like that. But this particular epilepsy syndrome is associated with myoclonus. Most commonly in the morning, what the patients won't come in and say, Doc, I'm suffering from myoclonus. They come in and go, you ask them, they don't complain about anything, but you ask them and they say, you know, I have trouble brushing my hair. Well, don't look at my hair. I never have trouble brushing my hair, but they have trouble brushing their hair in the morning because they're holding the brush, it pops out of their hands. They don't drink coffee until they've been awake for about half an hour because they're clumsy and they're going to drop it. Because they get these little quick contractions. Usually in the morning, it can happen all day. And the other thing they get besides the big convulsions are staring spells. Now, this is a syndrome that presents usually around puberty, early teenage years. So you go to the parent and you say, well, does your kid ever have staring spells? And they go, teenagers staring off into space, not paying attention to me. 100% of teenagers apparently have absence events, including my own kids this evening. But you understand why this could be completely ignored. And the myoclonists are like, you know, I guess it's just part of it. But then when they have the generalized convulsion, they show up in my office. And when you have those 3 pieces presenting in the age of onset, I know a bunch of stuff already. Odds are your neurologic exam is going to be entirely normal. Your imaging study is going to be entirely normal. IQ, intelligence, entirely normal. Average, superior, they go on and become doctors, lawyers, business executives. The Chief Justice of the Supreme Court probably has this syndrome, though nobody can get him to admit it, but that's probably what he's got. You may disagree with his politics, but he's a smart guy. It's never going to go away. There are patients who have genetically acquired epilepsies. I don't see most of them because they go away by the time they're 18. Now, Jim Wheelis, who was my predecessor, used to tell me he cured 100% of pediatric epilepsy. What he meant was he waited until they turned 18, then it was adult epilepsy. They're cured. But for most of those patients, by the time they turn 18, the epilepsy, they mature, the brain matures, the epilepsy goes away. What's called juvenile myoclonic epilepsy, that's what this syndrome is, doesn't go away. When they're 90, they're not taking medicine, they're sleep deprived or stressed out, they can have another seizure. Sleep deprivation, stress, and tiny amounts of alcohol can all trigger the seizures, which is really depressing when you're telling a 19, 20, 22-year-old, no, you can't. You're the designated driver. They're like, thank you very much. Not surprisingly, it's hard to get them to be compliant. Not uncommon for them to have a family history, but they don't have to. And they may not penetrate, because if you have, let's say you have a parent who only had the staring spells or an occasional myoclonic jerk, never had a generalized convulsion. They don't have epilepsy in their mind. So it could skip a generation or two, but there's a chance their kids will have it. And if they have it, almost every person who has this, most of the time they're going to respond to either tiny doses of Depakote or levetiracetam, Keppra. Majority of the patients can be almost completely controlled with these medicines as monotherapy. And I know all of that just from the presenting history. We do all the other testing. Oh, and the other thing is, if I get an EEG, it's going to have a very particular pattern on it. If it's abnormal at all, it's going to have this particular pattern. This absolutely confirms it. I also know that I have to watch them because they have a higher than normal incidence of depression and anxiety. Now that's true in epilepsy patients as a group compared to the general population, but particularly true in this group, even though they're well controlled. They may have no seizures on medicine and still develop the depression and these other things. Contrast that, that's one syndrome. Contrast that with somebody who comes in and they were like my mentor's kid. They had a febrile seizure when they were a kid. Now, when I said that that's a benign, that's febrile seizures, they're an epilepsy syndrome. One of the most common ones there is, and 90+% of those kids grow up and become people, and nothing happens, and they never have another seizure after that. But there's a group, small percentage, that's somewhere later in life, teens, 20s, they start having complex partial seizures. A lot of times they'll be preceded by some aura, they'll have weird smells or a feeling of deja vu, rising sensation in their stomach, and they're tried on several medications and medications don't work. The most common reason for medication failure that shows up in my office is a condition called mesial temporal sclerosis. Some of you may have heard of this. The scarring of the inside of the temporal lobe. And if you ask the people who get it, a large percentage of them had febrile seizures when they were a kid, even though most of the people who have febrile seizures never develop epilepsy. And what I know once they give me that typical presentation is they're probably going to have some problems with some kind of memory, because that's what the hippocampus does. Their seizures are probably not going to respond to medicine, even though we're going to try it anyway and continue to try it. And most of the time, the definitive thing that's going to fix them is taking the hippocampus and either vaporizing it with a laser or having my surgeon cut it out and put it in a jar somewhere. Shoot.
What do you mean by hippocampus? Is that the same thing as scarring on the...
If you look at the temporal lobe, so my temples are here, and I would draw it, but I'm the worst artist in existence. So hopefully a picture of a brain will show up at some point. Let's see, maybe we get lucky and there's a brain. No. All right. So just bear with me here. So if you imagine your brain is like that, you got the temporal lobe down here that's by your temple. You got a lateral temporal lobe, which is a part on the outside near the bone. You go around to the inside, there is the mesial or middle part. And there's a structure in there called the hippocampus, which is Latin for seahorse, because if you slice it the right way, it looks like a seahorse. That structure is amazing, because all of what you do in terms of your immediate memory, like if I say something and ask you to repeat it back to me, it's your hippocampus picking it up, writing it down, and then spitting it right back out. And it does this with all kinds of things. It integrates your emotional response to something, like the first time you see the girl who becomes your wife, and there's music playing, and all. It ties all of that stuff together, and it serves as the way that it can say, all right, let me see, I hear the music, she was wearing this perfume, and then the whole memory comes flooding back. And the hippocampus is critical for grabbing that stuff and pulling it together. In order for this to work, it has to fire really, 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 really fast, which makes it fantastic at doing its job, and unfortunately very vulnerable to developing epilepsy, because it's a structure that's primed to do sustained repetitive firing of neurons, which is exactly what a seizure is. There's something about the scarring that develops, and we don't understand it. There's like a genetic predisposition that's maybe activated by the high fever when they're a kid, or there's something in the environment. We don't have all the pieces put together. But something causes this particular group to go on and develop this, and sometimes the other hippocampus gets involved. That's a very bad situation. And we don't know if it's because genetically they're primed so that both of them are going to go bad, or this one convinced the other one to go bad. There's a lot of argument and debate about this. But what's very clear is most of these patients will respond poorly to medicine. And the thing that ends up working is removing the structure. So, well, when a patient comes in and they initially present, you do a bunch of imaging studies, blood work, EEGs. Many of you may have undergone all of these wonderful, fun tests. I'm in a tube wrapped up like this for several hours at a time. I'm not claustrophobic. And most of the time, we're going to be able to get some idea of what well, first of all, somebody's had one seizure. Do we have an idea of whether they have epilepsy or not? Because let's say you have one seizure, but I see this scarring on your I'm not going to wait for you to have another seizure. I know that you're very likely to have another seizure. Or you have one seizure and I get an EEG and I see what we call sharp waves or spikes on it. You're very likely to have another seizure. I don't have to wait for you to prove it to me. I'm going to go ahead and initiate therapy. So you do that initial that treatment. And what do we treat with initially? Medicine. Medication. Why medication? Well, what was the first treatment for epilepsy? What's that?
Shock.
Shock. Oh, the very first treatment for my surgeon loves this. The very first treatment for epilepsy was surgery. If you go to their burial caves in France, Eisenstein or something like that, and there's a 7,000-year-old skull that shows evidence of healed, what's called trepanation. Trepanation means that the surgeon cut out a piece of the skull, opened it up, put it back, sewed up everything, and let it heal. 7,000 years ago. The particular skull, I have a picture of this somewhere. The particular, this guy died when he was in his 50s. Now, 7,000 years ago, living into your 50s was advanced old age. So not only was it surgery, but it was successful surgery. Now, they treated, we don't know that this one had epilepsy, but we know that they used that to treat a lot of things: demonic possession, evil humors, curses, brain tumors, bad headaches. I don't know that I'd go for it if I just had migraines, but hey, you know. And seizures. Then, well, the next, this is, it drives me crazy, but the next thing that was probably used as a treatment was marijuana. Because it grows out there, and for some types of epilepsy, wild type, is that me? Sorry. For some types of epilepsy, wild type marijuana maybe had some ameliorative effect. Now, I can talk more about that later if people are interested. The bottom line is, if you ask me about epilepsy and marijuana or CBD oil and marijuana right now, I will tell you that I don't know. That there should be lots of testing done, and people should produce pharmaceutical grade compounds that we can test like every other drug. The biggest difference between marijuana or CBD oil and any prescription I write is that the prescription, that compound has been tested in double-blind placebo-controlled trials, and I have evidence it works. And I got nothing over here. Other than that, the fact that it's natural and it grows and people have pictures of it on flags doesn't make any difference to me. It may be popular, but that doesn't make me that it works. Okay. Then there were bromides in the 1800s, bromide salts, and then phenobarbital and dilantin in the early 1900s. And
Well, I took it in the 1960s.
Well, it's still around, it hasn't gone away. I treated somebody with bromides when I was a fellow, and that was something that was developed in the 1800s. And if you think about it, you say, well, you know, we have all these drugs at this point. There are, I bet it's going to say 20 different, look at that, 20 different anti-seizure medications available in the United States. Which drug do you think is the most powerful drug for stopping seizures?
Whatever, which one works for you.
That is as close to a correct answer as you're going to find. The answer is there isn't one. And there have been several head-to-head studies, not as many as we need, but several head-to-head studies, one in 85, one in 1990, one in 2002, Maharaj, I forget what year that was.
Yeah.
All of them came up with almost identical answers. You come in off the street, you have epilepsy, I put you on a medicine. Doesn't matter what medicine it is. About 47% of the patients will become seizure-free. And I'm going to tell you, now you're going to know as much as an epileptologist about medical treatment of epilepsy. So, I give you the drug, I increase the drug until one of two things happens. You stop having seizures, and you're not having side effects, and we're done. Yay. Or, I keep increasing the dose, and then you get side effects, and you go, I can't walk, I have blurred vision, I'm throwing up, my nose turned green and fell off. Well, hopefully not that. And at that point I go, this drug has failed. So I go to drug number 2.
How long did that usually take?
Depends on the drug, and that's actually more related to the frequency of seizures than it is to the medicine. Because if I'm having one seizure every 3 months, it takes a long time for me to figure out with one dose increase whether it worked or not. You're having 3 seizures a day, I'm pretty much going to figure it out in a couple of weeks. But most of the time, 2 to 3 months, yeah.
But doesn't it also rely like on the person, like if they're physically active, or like if they're taking any other medicine, or if they use ibuprofen? Like, can it affect like how the increases, or if you need to decrease?
No, yes, and no. There are a lot of things that will relate to seizure control, but in terms of whether a particular medicine will make somebody seizure free, I mean, there are a lot of ways that you can spoil that particular broth. Like I've got one patient who comes in who's got JME, and I say, how many seizures have you had? And I said, did you stop drinking yet? No. Well, if you're pouring lighter fluid on the fire while you're trying to put it out, it generally doesn't work very well. So to that extent, lifestyle choices do make a critical difference. Sleep deprivation activates virtually every kind of epilepsy. So if you either have sleep pathology, or you're 25 and you like staying out late, with your, even not drinking or drugs or nothing, you just like staying out late and being sleep deprived, that lifestyle choice is going to have an impact. Not taking the medicine, strangely, I tried, it doesn't work, it's in the bottle, it doesn't radiate outwards, it's not if we ever come up with a medicine that does that, though, that would be fabulous.
I tried it as a teenager.
What's that?
I tried it as a teenager.
Yeah, it doesn't work very well.
No, it didn't.
But go ahead.
But what I was asking about was like the metabolism, because what my neurologist had said, like my medicine wasn't working because my metabolism was going too fast and it was processing the medication.
That's
but even
true.
though it was reducing the amount of seizures, it wasn't reducing it to the number he wanted, so he had to change my medication due to my metabolism.
Well, most of the time, the one drug where that will be true consistently is Dilantin.
Yeah, that's good.
Right. There's a small percentage of the population that are what we call fast accelerators. And you don't bother giving them Dilantin because they'll just chew it to pieces. Their liver will chew it to pieces. It's like, a dog bone to my dogs. They'll just rip it apart. No matter how much Dilantin they get, you never get a decent level. But that's just Dilantin. And if you switch them to any of the other 20 plus drugs, and we have drugs that are not hepatically metabolized, that don't interact with other medicines, and this is why we like them, then the drug either works or it doesn't work, but it has nothing to do with metabolism or drug interaction. That can have an effect, but when you recognize that, you simply use a drug that isn't affected by it. That said, even with those new drugs, because we got drugs released this year, percentage is exactly the same. 47% for the first drug, go to drug number 2, 16%, go to drug number 3, 6%, go to drug number 4, 5, 6, less than 3% per drug. So something happens after 2 to 3 drugs. We'll get back about talk about it in a second. Something happens after 2 to 3 drugs where the population is different. 2/3 of the patients who have an epilepsy where you place them on medication, they stop having seizures, and that's it. And they live happily ever after. And then the other third, roughly, have what's called medically intractable epilepsy. And for the majority of them, no matter how many drugs you try, you never get them controlled with medicine. Now, less than 3% per drug is not zero. And I have personally seen multiple times where we go, well, we'll try another drug. And drug number 19, magically, zanisamide, and I'm just picking a name out of a hat, it could be anything, it could be Sabril, it could be zanisamide, it could be Tegrid. That's the one! You know, the rockets go off and the seizures stop. And then they come in, they go, this is the greatest drug ever, but you can fill in the blank. And I have heard that about every single drug on the market from some patient. For them, that was the drug. Failed everything else. That's why you keep trying. However, everybody recognizes, you can get it down to about 7, dizziness, headache, blurred vision, nausea, balance difficulties, waging. It's like the 7 ugly dwarves or something like that. These are drugs that work in the brain. And in the process of attempting to arrest the abnormal electrical activity, they can have an effect on normal electrical activity. And that normal electrical activity will produce all of that stuff at the top. The ideal is that you have the drug just enough so it stops the seizure activity, but not so high that it's producing this other stuff. Now, ideally, you need this much drug to stop the seizures, and they get sick when you're up here. But by the time you're one of these medically refractory patients, yeah, well, you're like this. And I will tell people, I teach people to use one drug at a time. You come into my clinic and you go, he does not practice what he preaches. All these people are on 2 drugs or 3 drugs, but that's the population that I treat. At the point that they've gone to, they're really good neurologists in the community. They're smart people. This is a good city for medical care. And at the point that they run out of options, that's when they send them to me. So many of these patients are on 2 medicines or 3 medicines or more. It doesn't help much. We get a lot more about it, a lot more of this stuff in terms of side effects. So,
I have a question.
please.
Are you saying that it's the medication that's causing the difficulty in thinking and learning, or is it the actual seizure?
Oh, that is an excellent question. That's a fabulous question. Because if you ask most of the patients, drugs are making me tired, drugs are affecting my memory, drugs are making me sleepy, drugs are making me depressed. No, I'm taking a medicine, I have this problem, it must be the medicine. The reality is sometimes that's true. Sometimes.